Okay.
All right, good morning, everyone, and welcome to this morning's GRC CMIT. I am Tracy Nauer, the Vice President of our Home and Community-Based Services Division at Direction Home Akron-Canton Area Agency on Aging and Disabilities. Direction Home is one of 12 area agencies on aging in Ohio, whose goal and focus is to help people of all ages with disabilities.
That's all. I want to say hello.
Stay at home and age. I lead our CMIT team at Direction Home. CMIT stands for Care Management Interdisciplinary Team. This team was created many years ago in collaboration with our partners at Summa Health and Northeast Ohio Medical University to assist our care managers with difficult consumers and situations, foster collaboration in the community setting, and provide education to students and residents. The team is comprised of a geriatrician, Dr. Jen Drost, with us today, a pharmacist, Dr. Sue Fosnot, also with us today, a master's prepared nurse, which is myself, and nurse and social work care managers, pharmacy and medicine students and residents. CMIT provides a forum for care managers to discuss consumers with complex physical, mental, spiritual, and/or psychosocial needs and facilitates an interdisciplinary team discussion for recommendations and suggestions to improve the health and lives of the consumer and promote continued living in the community setting. The committee meets weekly and evaluates the consumer's problems using this multidisciplinary approach. Recommendations to assist with and resolve the consumer's problems are discussed, transcribed, and then shared with the consumer's primary care physician and any other providers. Having this weekly team meeting is very important for successful outcomes. Research has shown that team-based delivery of care results in fewer hospitalizations, reductions in length of stay, fewer drug prescriptions, promotion of community-based living, greater satisfaction of consumers, and often lower mortality rates. An interdisciplinary approach promotes care coordination and comprehensive means of providing care. Pat will be discussing our case today. So Pat, if you would introduce yourself and then tell us about your client, and Denise can share the screen.
Hi, I'm Dr. Pat Vermeersch. I'm a retired professor from Kent State, but I'm also a geriatric nurse practitioner at Access Point in Kent. And I have the benefit of the lived experience of being geriatric as well as seeing my patients. So it gives an interesting perspective. Can you pull my notes up for me on the screen? There we go. And then I'll have to sort of kind of read through it. So this is a gentleman who is actually married. His wife still lives, and he's 76 years old. He's a retired car mechanic. I don't really know his education or reading level, but that may have impact on things later on. He does live in his own home with his daughters and some grandchildren, and there's a property next to that one that also has a house, and the other part of his family lives over there, which complicates his insurance picture. His main diagnoses are very poorly controlled diabetes. His hypertension is well controlled. He does have hypercholesterolemia. That's also very well controlled. He's got a history of stent placement. And recently, he was just diagnosed with AFib and paroxysmal VTAC. However, he refuses any surgical intervention. And so the cardiologist has now added him onto diltiazem to help with that. Could you scroll down or scroll? There we go. So this is a list of his medications, pretty standard stuff. He's on the maximum dose of metformin. I just recently added the glipizide at 2.5 milligrams, primarily because it was the cheapest option. He had been on it before, but had at 5 milligrams, and his daughter had reported that he was having some dizziness, so I had stopped it, and then his blood sugars went back up again. So the diltiazem is at 180 once daily, and he's on an aspirin daily, and he's on 20 milligrams of atorvastatin, which I reduced recently because of his labs that were coming back. So you can looking for pharmacy for help. Did I make the right decision, or do you have a different choice? These were his labs. So his A1C was now 13, so he's well into double digits. I did not do on microalbumin yet. His CBC basically was normal. His CMP actually still looks really good, except for that glucose. It was well over 200. It tends to run over 200, and he tells me, and his daughter confirms, that when it gets under 200, he starts feeling really crappy, and it looks like he's having a hypoglycemic episode. The most recent lipids were, his total was 87, his HDL is 38, so it's low, but not super low, as like I've seen. But his LDL was down to 40, and that's what began to concern me overall, was with his lipid profile, and he's lost some weight as well. He's full ADL. He's still independent in all of his independent activities of daily living. He's has a little bit of unsteadiness on his feet, but otherwise he's pretty functional, quite honestly. He doesn't have any mental impairments. Has a very consistent, positive, and I put forceful attitude because I don't know how else to describe it. He refuses to go to the ER or be hospitalized for any reason. That's been consistent over time with him. The daughter's been working hard. So in spite of this man's age, he does not have Medicare, except I think Medicare Part A. So he's basically out of pocket. And because he owns those two properties, he's not eligible for Medicaid either. The daughter's trying, she apparently got hold of some kind of counselor type person to help her. And she's working very hard to try to get him onto some insurance, because that's affecting what's eligible, or what his options are. Scroll down some more to the strengths and weaknesses. So, his strengths are, he really loves his family, and he has an extensive daily contact with all of them, because they're like he's physically living with them. His daughter is very engaged with her dad, despite his independent and forceful nature. He does take his medications daily, so that's good, and he is cognitively intact. Barriers are that he declines, and again, as I've presented before, he does not want any type of needle. He declines any referrals because of cost, and his typical response is, well, what are they going to do anyway? I'm old and I'm just going to die eventually, or words to that effect. He's unable to afford the cost of the glucometer strips and lancets, and he doesn't want to do it anyway. So the few that we have gotten, his daughter, I think, went to Walmart and got a Walmart glucometer, and she checks it occasionally, but and he reports too, it's generally over 200, and if it gets below that, I feel terrible. So these are my main concerns. Is it possible to get him any sort of insurance based on you have more experience with this than I do? He does own two properties. They are side by side, and he refuses to sell one. That's just not on the table at all. How do I handle his worsening blood sugars? He's got a very poor diet. He's a meat and potatoes kind of guy. He declines changing his diet. I know the issues with glipizide, but like I said, cost is a problem. And then my question is his cholesterol due to malnutrition? He did lose, he has steadily lost weight over the last year and a half, and he's now down to a BMI of 18. Should I reduce the atorvastatin? And I already did. I went from 40 to 20, but I just is that a good idea or a bad idea? I mean, I realize his cardio risk factors. He doesn't smoke, by the way. He had a very bad experience with a close relative with dementia, and who lost everything when they had the durable POA. So I have raised, and quite pointedly raised, the issue that if he really wants to not have anything done, he really needs to get this in writing, because he's putting his daughter and his family and all of his providers in a real tough position when we don't have in writing what it is that he wants. So I don't know if he heard me or not. So floor is open.
So Pat, he has a wife as well.
He has a wife, and I don't see her, and I don't know anything about her. So I don't know if she's in good shape or bad shape or whatever.
Okay. And then he doesn't have Medicare?
I'm trying to remember. I was trying to pull up his chart. If he has Medicare, it's only Part A.
Okay. So
he doesn't have any outpatient stuff. So we've got him on a sliding fee scale. Okay. And his kids, his daughter actually asked about, instead of using the daily finger sticks, if he could get a continuous glucose monitor. She's been reading about it and hearing about it.
Mhm.
And I said, well, there's still a stick with that. I mean, initially, but my understanding is it's pretty minimal and it's once a week. And I said, maybe, but usually my experience with that kind of stuff is somebody needs to be on multiple drugs, and the insurance people don't like that. So she keeps telling me that she has a brother who would be willing to pay for this stuff if we can figure out how to get him on it. So somebody's got some money because they're paying for his supplies to check his blood sugar. So I think there's somewhere, there's some money here. They all do, but it's I don't know if it's a low income family. I don't know that much about them.
Yeah, and I'm not sure any programs through the manufacturer to offer it either free at a reduced cost. I don't know, Sue or Dr. Drost, if you have any comments on that.
So for those patches that you wear that you can then put a meter up to and measure your blood sugar, I don't know of any patient assistance. I've looked for that before, and I'm pretty sure that there is not. I'm not sure. It might be covered under Medicare Part A. It's usually pretty hard to get, except for certain insurance companies are now giving them out to a lot of people because they have shown to improve outcomes. I don't think it's a Medicare Part B type of coverage or Medicare Part D type of coverage. I think it might be covered likely more under Medicare Part B. So
Okay.
I think that we are coming up to the enrollment period for Medicare Part D. And I think that you may want to encourage him to at least sign up for Medicare Part D so that his medications will be covered. And usually that coverage you can get fairly inexpensive. A lot of times it's about $30 a month. So maybe that's not inexpensive to him, but he's probably getting close to spending that much on some of his meds.
Right.
So that is a thought to look into that. The glucometer strips and the glucometer at Walmart, I'm familiar with that. That's what I do recommend to people, to use those when they can't afford the other glucometer strips. They're pretty inexpensive. I think the last time I was in Walmart and looked, it was like $5 for 50 strips, and the glucometer is like $10. So it's a pretty inexpensive way that he can still check his sugars.
Okay.
Some of the other medications, things that you have on there, to start out with how to handle his worsening blood sugar. The glipizide certainly is not usually my first choice, but you are in a position where he doesn't have very much cash to pay, or it doesn't seem to appear to have very much cash to pay. And if he qualified for your sliding coverage at your clinic, then he probably does have some cost barriers, because I imagine that they want his financial information for that to be done. So I would kind of agree with you that glipizide's not great, but it will definitely help to get his sugar down. Whether it would help to get his sugar down enough, I'm not sure. I like the idea of checking his blood sugar, especially if he has any dizziness. So because he's had problems with that before, I worry that his sugar may take dips when he's using the glipizide. There is a new oral drug that works fairly well. It does have patient assistance programs and coupons. He doesn't have Medicare Part D, so he will probably qualify for these. The name of this drug is Rybelsus. So it's a GLP-1 drug, but it's oral. It's been available for just maybe 5 to 6 months. So I think he might be able to get that either for free or minimum. And Pat, I can send you more information about that.
Yeah, that'd be great.
So it's a GLP-1. He couldn't use it if he's had any kind of thyroid tumors or in the family, or pancreatitis. But otherwise, it doesn't have a lot of side effects. It can cause some GI discomfort when you first start taking it. And
Okay.
I would definitely warn him of that. But it is pretty effective with getting blood sugars down. So with not wanting to use any kind of injection, then I think that would be an option. So I'll send you some links to basically how to get the patient assistance for that. I don't know if you have someone in your office that takes care of that usually, but that might be
Yeah,
a choice.
I think I'll pass it on to our pharmacy because I think they can actually do that. I talked to her a little bit about, what my choices were for add-on medications with this guy, and I couldn't get hold of her right away. So I had to make my own decision. And I thought, okay, I'll try the glipizide again until I can figure out what else, because I know he needs one of those other categories, and I couldn't make up my mind about what was the most cost effective. What about the dropping of the cholesterol medication from 40 to 20? Is this?
So I just read about this. So he hasn't had a stroke, he hasn't had an MI, and he doesn't have peripheral vascular disease. Is that correct, Pat?
Well, he had a stent.
Oh, he does have a stent. Okay.
Yeah, he had a stent, and he's not on other than the aspirin. That was the cardiologist had put him on the higher dose, which is my experience with cardiologists is they typically push those higher doses until the patient goes, no.
Yeah,
but
so
I read about, I thought there was some indication that if cholesterol gets too low, it could be a suggestion that the patient's malnourished, and he is steadily losing weight. He doesn't eat real well or real regular, which is another diabetic concern. So
I just read up on this and read a bunch of articles about statins in older patients, basically. So they have debunked that idea that your cholesterol can get too low. So they're not saying anymore that you should back off on it if the LDL ends up too low, that you can. 40 is certainly not something that they would consider too low. And then if a patient has had basically one of those events, and I would count a stent as one of those events, then it is preferred to still use the high intensity statin. So the 40 milligrams may be preferred. Now, the exception to this would be if he's having side effects. So if he's saying I'm having muscle pain or, and probably the side effect that's probably the most concerning for him is that it can actually worsen diabetes, or actually they say it can cause diabetes, or at least be associated with increased risk for diabetes. So that is one. I don't know that, how long ago was the stent done? Was it a while back or was it just recent?
No, it was, whoops, what happened?
I can still hear you.
Oh, okay, my screen just went kaflooey here, hang on a second. It's been at least more than a year.
It's been more than a year.
Yeah.
Yeah, if he wasn't having, my opinion is, and I don't think that it's wrong, I think what the guidelines say, even for people who have had events, that you, for an older patient over the age of 75, that you could go to moderate intensity statin. But I think from my reading, if he's not having side effects, I'd prefer to see him stay on the high intensity statin.
Okay.
Yeah, I agree with Sue. Yeah, because it's not just the number, it's the pleomorphic effect or anti-inflammatory effect of the statins for his vasculopathy. Yeah, thank you.
Okay. All right.
I would though dig in more into the the malnutrition, the weight loss, that piece though. And I think you're right to kind of maybe not make changes in the statin related to that, but to be concerned about how if his LDL keeps getting lower, even on a dose, or his cholesterol in general keeps getting lower, of being a marker for malnutrition as well. And a BMI of 18, he doesn't have a lot to lose before he really gets into kind of into the danger zone, if you will. So yeah, it's his poorly controlled diabetes contributing to that, or kind of circling around from that standpoint. And then I guess I'm just also, this whole, he's, what was he, 74 or 78?
Yeah.
76, I think.
76.
Not, okay. Not, I mean, he's older, but he's not, old, right? So this whole thought process that a lot of folks get into of, you know, I'm 60 or I'm 65 now and I'm just old, and what are they going to do? You know, I think that that's, you know, likely contributing to a lot of his barriers to his health. And how do we support people to kind of wrap their head around, right? I mean, he gets these things under control and there's nothing to suggest he can't live, you know, independently, continuing to manage his own affairs for another 15, 20 years, right? Like,
Yeah.
So,
Yeah,
and I know you said he's typically pretty positive, but have you dug in or thought about doing any other additional just screening types of things? So pulling out, you know, the PHQ and doing the rest of the questions, or, you know, an anxiety screen or something like that, just to dig a little bit more.
I think that's a really good idea. I mean, we screen everybody every visit for dementia, but he's kind of one of those guys that he's going to tell you what he thinks you want to hear. So I'm not sure that our screen is capturing it very well. And since his daughter's always with him too, I might need to chase her out of the room. And she's very supportive and really wants to help her dad, but in some ways, I've run into this before where sometimes there's too many women in his life telling him what to do, and he just starts pushing back because there's too many women, and I just add to that. So I might, I'll see if I can, we use the PSQ-2 as a general screen, and then the 9, and they don't typically go any deeper than that. So, and I like the idea of also checking for anxiety, because some of this stuff might come up if I approach it differently. So I'm going to add that to my list of things to check the next time he comes in, and see how he's doing, because that's a good point. And I was pretty blunt with him about the durable power of attorney, and I understand the fear that he has, that he doesn't want to lose control. And so I was trying to approach it from that standpoint of that. That's great, that's wonderful, but you might not die in your sleep. It's another one of those kind of things. People don't think about the fact that you may have a stroke and you're perfectly cognizant and you can't express your wishes. Somebody needs to do that. And I don't know what kind of shape his wife is in, and I don't, you know, who he names on his durable POA matters a lot. So I don't know where this is going to go, but I appreciate your suggestion, though. That's a good idea. Anybody else?
I guess along that same line that you were talking about, just because his hemoglobin A1C is at a point that it really does look like he most likely will, it would be preferable to have him on insulin at some point, most likely. But just that same type of thought about that, keeping his blood sugar under better control will not only help to keep him alive longer, but also to prevent him from having a stroke. Because somebody like him probably, like you said before, wouldn't want to live with all the issues that go along with having a stroke. So kind of thinking about it from that stated point. And then the idea that, you know, these days, it's not like you draw up the insulin and have to give it to yourself with a needle, that there's a lot of different types of insulins that are available that really are just like, you just push it up against your skin and make a click and you have a little pinch. It's not as big of an issue to use it as it used to be. So perhaps, you know, one of those products would be something that he would be willing to try. Although, you know, it does say the Ribelsis might get him down pretty good. It doesn't sound like he's overweight at all. So, but I also always recommend, if the family's willing to like take a walk with him, have him get some type of exercise every day, that will also help his sugars.
Okay. Yeah,
my concern with increasing his glipizide and his irregular intake of food, and he's at a very high risk for hypoglycemia, and that's gonna push him back, you know, and be resistant. I found it very helpful to really sit down and do motivational interviewing. with, where are you at with this? What makes, what makes your life better? What makes it worse? Where can we go with this? Who can help you with this? What motivates you? I mean, my father was a great example of this. He was a longtime smoker, and he drank probably too much. And his doctors just asked him, what do you want to do in the next 10 years? And how do you want to die? And and within a month, he had quit drinking and quit smoking, just by identifying, what keeps him alive and what he wants to do in the next 10 years. And it was very effective. So, and I've only, in the 20 years that I've been a diabetes educator and had to put, get people to, accept insulin as their next medication, I've only had 3 people that did not, take the insulin. You just have to figure out what motivates them and, how you're going to go about doing it.
Yeah.
So
That's a good plan. I think that's also very good suggestions. Before we close for the day, can I give you some feedback on a different case? That just to let you know how it played out.
Sure.
Something came on my screen here, but I don't think it matters. So the gentleman that lived in the van, you remember him? Unfortunately, he continued to, he was another one that continued, also older, no insurance and whatnot. He ended up getting an extremely bad wound on his back. And we had to actually send him to the emergency room. And from there, he ended up in long-term care. So at some point, so he's out of our system at this point. I tried to call him, and I did speak with him on the phone, and he's completely given up at this point. It was very, very sad. Nobody seems to be willing, and he's on basal prandial insulin now. So they're poking him all kinds of all the time. And it was very sad. I was very sorry to see that happen, but he was, so he did go to the emergency room. The good thing was, though, he did get his durable power of attorney and everything set up. So that happened. So at least that much we were able to be successful with him and get that done. But I was very sad to see that this happened, and I don't have a good feeling that this episode for him is going to go well. I don't know that he's going to he went to an intense rehab, and he said it was too much for him. And so he found a different nursing home, and his current primary person is actually out of state. So the whole situation kind of went down the tubes, and I was sorry, but I felt like we had some success with him. We did meet his goals. He was another one. He wanted to stay independent. That's what he wanted, and continue to care for himself. And he was fine up until that point. And it was the pain of this wound is what brought him into the clinic, but it was too big and too deep and too infected for us to be able to manage. So off he went. And since he did have Part A Medicare, then that allowed him to get a whole bunch of other stuff. And apparently somebody there picked up the pieces and sort of tried to keep him going. So I'm hoping that he does get stronger and start to feel better, but I just personally don't have a good feeling about it. So anyway, I just wanted to let you guys know about that one. So we tried and we did our best. And I do appreciate all the suggestions I got for him. So I think in lieu of everybody's time, we should probably end this unless anybody has any additional comments.
I just want to tell you that I put a couple of things in the chat. So Denise will make sure you get the chat. We have some Medicare sessions that will start here in October, maybe for this family to help with what Medicare benefits he might be able to have.
Okay.
And then I asked if there's any nutrition counseling in your office, if that's an option.
We don't, and I actually brought this up with my chief medical officer, is that we really could use a good nutritionist in our office, even if it's part-time, and not just for our older folks, but for everybody. It's apparently something they've considered, but right now they're so busy trying to hire providers because we're expanding services to the LeBron Family Center. We're going to be, the access point is going to handle all the primary care there. So they're in the process of trying to figure that out, in addition to which we expanded our building offices in Kent, and we don't have enough staff right now, like all the healthcare agencies, but yeah.
Well, then has he been seen by an endocrinologist? So, you know, they have all those resources in an endocrinology office. Maybe he needs to go there.
Which, my current guy?
Yes, the one you presented today.
Yeah, and I think my community health worker mentioned that SUMA has a special application or something for folks that don't have insurance, to be able to see a specialist, because I did call up O&M and they don't have dermatology and they don't have an endocrinologist. So that was not an option for him. But then he mentioned about this, and I didn't know if any of you, Dr. Dross, I know, left, if there's something at SUMA for specialty people that need to be seen but don't have insurance.
I don't know.
So Pat, I know of a couple different things. Is I know that just like it's done at your clinic, is that people can apply for like fee forgiveness, I think is what they
Something like
call it.
Okay.
So you would go through the finance area, and they would basically evaluate your financial situation, and there would be reduced fees. So that is something that can happen. And then I know through Family Practice Clinic that they are expanding what they call their special care team. And their special care team is for patients that are difficult. So difficult to control for one reason or another. Medication adherence and other adherence is definitely one of those issues. And they are getting together a team of people that would basically be available at that patient's office visit. So it would be like a one-stop type of thing that would happen. So those would be two resources.
That'd be great. Okay.